What best can be achieved by contralateral C7? And our protocol, first I would like to explain, it's a modification of Goose procedure, where he takes a vascularized ulnar nerve graft with contralateral C7 and try to innervate as many nerves as possible. It's a single stage procedure. And this we published in IJPS. First thing is we search for the donors, search for any ipsilateral route is available. The remaining donors are all, whatever is available, we'll try to utilize. Of course, nowadays we don't take phrenic now. And these are the recipient nerves we try to target. For the shoulder, suprascapular, axillary, and nerve to serratus anterior. For elbow, biceps brachialis and triceps. Forearm and hand, entire median nerve, and radial motor branches. And this is our current scheme. We target 9 nerves. Along with that, we also add static appendoplasty and tag all the FTP. This I like to call it as all-in-one or whole-in-one reconstruction. And based on the superior nerve collateral artery, we can take a vascularized nerve graft, and macroscopically you can see it will be highly vascular. On close observation, you can see the pulsation there. Can you see the pulsation there? The vessel will be there running for about 10 to 15 centimeters. We also did a ICG study because there is always a question whether the distal end, that is the end towards the Guyon's canal, whether that will be vascular. And here you can see the dye coming out of the cut end of the vascularized ulnar nerve graft. This is almost about 52 centimeters length. And earlier we were taking only VUNG for entire thing. And subsequently we thought we had to target only the forearm with VUNG and use other nerve grafts for axillary and biceps. So we started taking long nerve grafts for axillary and biceps brachialis. But sometimes we lost what we are, the biceps which we were getting earlier, we lost it. So nowadays we try to innervate elbow flexion by dual source. One will be by a long nerve graft and the other one will be from the VUNG. And occasionally we also target like this. We target the VUNG for musculocutaneous and median nerve, and the distal runoff will be connected to the motor branches of radial nerve. So all kinds of permutation combination we try to do, and this is called as all-in-one or whole-in-one reconstruction. And this is the static partial FCU appendoplasty and tagging the FTP tendons. So now we will come on to the results. How are the results? Do these limbs become independent? Can they do bimanual functions? Can we pneumatize both agonist and antagonist from the same nerve? And what about the prehensile function and the percentage in which they get the results? This is about 10 years post-op, a total palsy, and nothing was available. We took C4, C7, and intercostals 3, 4, 5. And this is 10 years post-op. And here you can see, and almost a very good shoulder. The shoulder has come mainly from the axillary and spinal axillary to suprascapular. And elbow, because we utilized C4, his elbow flexion was not very powerful, but its triceps was good. And he recovered good wrist extension. You can see even supination, pronation is there. The wrist extension, he didn't get finger flexion. He got only a wrist extension. Now you can see that's a wrist extension. It is independent. You see he is not using any movement on the opposite hand. So it is an independent movement. So can we neurotize both agonist and antagonist? And here you can see a similar patient, total palsy, the left side we have done. He can both supinate and pronate. Supination of course comes from biceps, but pronation is also there. Once he gets a finger flexion like this, we give an out trigger and try to strengthen the finger flexors. This is another patient, 3 months, end of 3 months we operated. And this is about, now he is almost about 8 years post-op now. He is able to do bimanual function. And if you see this left upper limb is the reconstructed limb. This doesn't look like a paralyzed limb. That is the beauty of total nerve reconstruction. And he is the same patient. And here you can see even the thenar muscles recovered in this. This is the only patient where I got the intrinsic recovery also. And he can dress up himself and he can look after himself and use it as a good supportive hand. And you can see now he is able to lift the chair, which is almost about 8 kg or so. This is a plastic chair. And he can lift it. He can control it. And this is about 8 kg. He is able to lift that. Because he was working in his own company where he used to lift oil cans. He always lifts this, uses the left hand to lift heavy weights. And this is another patient where I want to show where C5 was available. Because C5 was available, his shoulder abduction was, which we gave it to axillary, his shoulder abduction was very good. And you can see how nicely they're able to swing their arms. They no longer hide their limbs. And the good elbow flexion, extension. That is the amount of finger flexion they get, and is able to do bimanual functions. And this is the patient where we have neurotized median and musculocutaneous, and the distal runoff was given to the radial. And this is about 5 years post-op, a good shoulder, good elbow. Of course, his triceps was a little weak, and wrist extension was not there, but finger flexion was there. And he is also rehabilitating well. He is able to use his hand as a supportive hand. And all this, wherever whoever gets a good flexor, we give this outrigger and try to strengthen it. And what kind of sensation do they get? And if you see, my colleague is testing the sensation in the reconstructed limb. And he is touching the median nerve territory. And he is asking him, and he says he is able to feel. And now he's asking, where does he feel? He is able to feel now. And he's asking where? And he's showing the other hand. That's where he feels. And the thumb is also, he's able to feel. That is the kind of sensation they get in all these patients. Whereas the median nerve territory he has, ulnar territory doesn't have. So we have done 66 patients. Nearly about 80 to 90% the shoulder and biceps and even triceps, I can assure, they get good results. Whereas about 30% get finger flexion, and nearly about few people only get about finger extension. So main advantage is a single stage procedure with a stable shoulder and elbow. And we also try to get some functioning hand wherever it is possible, and try to get some sensation also. But the main advantage is the recovered patients, the limb looks normal, and they can use it as a supportive hand, and neurological pain is also less. And we are able to rehabilitate back them into the society. And I feel C7 is a boon to total palsy, and judicious use can give encouraging results and rehabilitate the patient. But you must give every second to the recovering now. Thank you.